Hello everyone, this is Giacomo Fabbri, and in this my short lecture I want just to speak about the soft tissue management around the implants. In particular, I want to point out how we can transfer correctly the soft tissues architecture, the soft tissues morphology to the lab. In fact, we know how normally when we face with treatment like this, when we have to manage a single tooth replacement, normally we spend lots of time to recreate the soft tissues, to recreate the bone volume, to recreate and redesign the soft tissue architecture using the temporary restorations and working with the composite in order to redesign the zenith of the soft tissues, the papilla, and all the profile of our restorations. So we spend a lot of time. We treat the patient, sometimes we have to extract the tooth, we have to wait for the complete healing, we have to face with the temporary restorations, then we have to face with one or more surgeries, and then finally, when we have the complete healing of the bone and the complete healing of the soft tissues, we can work prosthetically with the temporary restorations. The temporary restoration is a critical aspect in the prosthetic therapy, in particular speaking about the implant supported rehabilitations, because in the aesthetic area mainly, the temporary restoration is the key point in order to idealize the soft tissues architecture and to idealize the prosthetic outcome, both from a functional and an aesthetic point of view. For example, if we have a look at this case, we can see how at the time of the re-entry, we place a temporary abutment, a screw-retained temporary abutment, in order to place immediately a temporary restorations. And step by step, we start to work on the temporary, adding some composite in the subgingival portion in order to idealize the soft tissues morphology and to achieve this kind of result. So at this time it's really important to take a good impression in order to give to the dental technician the chance to have a model that is absolutely reliable, both in terms of 3D implant position, then in terms of soft tissue architecture. So in these simple clinical situations, the technique considers to create a sort of customized impression coping using the temporary restorations. So we connect the temporary to an implant replica, we create the negative shape of the subgingival contour of the temporary, and thanks to using some acrylic material with some composite, we are able to create the morphology of the temporary, the subgingival morphology of the temporary on the impression coping. In this way, if we take the impression, we are able to create an ideal model, and on this model, the dental technician can realize a perfect abutment with a perfect blending between the soft tissues and the prosthetic components, and then we can create the final crown. And if we work in the right way, we are able to achieve this kind of good and stable aesthetic results. Here we can see the X-ray, we can see the baseline, or better, we can see the situation before the treatment, and now we can see the final result. So, just to summarize the technique, in this case where we have just to manage one single implant, we have simply to connect the temporary restorations to the implant replica, then using some silicone material where it's important to be able to recreate the negative shape of the temporary. And then here, exactly in these pictures, we can see how we have the implant replica embedded inside the silicone, and at the same time we have the negative shape of the subgingival portion of the temporary. So now we connect the impression coping to the implant replica, and we fill the gap that it described the subgingival portion of the temporary with some composite. In that way, after the light curing, we can see how we have the new profile of the impression coping. We are able to recreate the same profile of the temporary on the impression coping. In that way, when we will take our impression, the impression coping will maintain the soft tissues exactly in the same position of the temporary. And this is crucial, this is really important, because in this way, when we receive the final abutment from the lab, for sure we will have something that will be sit really well in the soft tissues, and absolutely it doesn't require any kind of important adjustments. Here we can see how the red lines compare the subgingival profile of the customized impression coping with the subgingival profile of the temporary abutment. And this is what's happening in case of single tooth replacement. But I think that now we have also to point out what we can do when we have to manage always the anterior segments, but in particular when we have to manage the partial rehabilitation or maybe also the extensive rehabilitations, where it's really important also to evaluate how to transfer to the lab not simply the subgingival portion of the running room of the implants, but also the pontic area of our rehabilitations. In order to describe to you which is the technique that today I use for this kind of specific situations, I want to introduce the first cases that I managed many years ago, in 2008, so more around 10 years ago. It was really a really challenging situations, a really challenging case, because we have this kind of atrophy, really big atrophy in the frontal area. And of course, in order to achieve a good integration of our implant-supported rehabilitations in these patients, she was a really young patient. So in this case, we decided to work with an important GBR in order to recreate the volume that we have lost, the bone volume that we have lost due to an important trauma. So this case was managed from the surgical point of view from Dr. Emilio Mascara, and these pictures describe which was the surgical approach with GBR technique. So first we worked with the first surgery that it was finalized to recreate the volume, the bone volume, using a not resorbable membrane, titanium reinforced not resorbable membrane. In this picture we can see how is the situation when we remove the membrane after 6 months. And the same day of the surgery we decided to place immediately the implants, and in the same day we work with the new GBR but using resorbable membrane. The implants are placed and then we wait other 4 months. After 4 months we work with a soft tissue graft, and then we wait again after 2 months, and then finally we are able to do the re-entry. So it means that these patients faced with 3 important surgeries. This approach allows us to achieve an important volume of bone and soft tissues. And now, when we have a good soft tissue volume, we take the impression and we create the temporary restoration that always, also in this case, represent really the key factor of our success. We can see from these pictures how the temporary restoration in the beginning has a really flat profile in order to don't compress, in order to don't push too much on the soft tissues. And step by step, working with the screw-retained temporary restoration, we are able to change the profile, the subgingival profile, creating a more scalloped profile, recreating the morphology that we need around our restorations, and in particular also in the pontic areas. So we work in this direction, so we work on the temporary restoration, adding some composite in the pontic area. We can see how the result after simply 1 week, because it's important to work step by step, and it's important simply to add composite without to use any kind of drill or burrs, because if you use drill or burrs, you cut away the bone and the soft tissues, while if you use composite and we push the soft tissues, we move the soft tissues and the volume. So step by step we are able to redesign everything, to recreate a sort of pseudo-papilla. And this is exactly what we have to do. This is exactly the role of the prosthodontist in this case of clinical situations. And it's really important to pay attention on each details in this kind of prosthetic approaches. Here in details we can see how the soft tissues are after 6 weeks, and here we can see how the soft tissues are after 8 weeks. So we are able to recreate a good scalloped profile with a good pseudopapilla. But the problem of these soft tissues is that this morphology is created thanks to the temporary that maintain the position of these soft tissues. So it means that when I remove the temporary and also I wait 5 minutes, the soft tissues morphology will be changed if I take another pictures. So it's important also in this case, it's important also in this situation to find a solution in order to be able to transfer to the lab this kind of situation. The situation that we have tested in the mouth per month, and we have created in many weeks of treatment in our study, in our clinic. So the topic is that we spend 2 years to recreate this kind of volume, this kind of soft tissues, and so it's not possible that we don't have a good technique to transfer this crucial information to the lab. Here we can see a comparison between the soft tissues before and after the conditioning, and we can see how there is a huge difference. So it's really important to be able to transfer to the dental lab the ideal situation in order to receive an ideal framework that it doesn't require any kind of important adjustment with any kind of end piece, and with the risk also to overheat the framework, in particular if we work with zirconia framework. To give you the ideal idea about what I mean, I want to show you these pictures. In the left side we can see the patient when he arrives in the office. I remove immediately the temporary and I take the pictures. And on the right side you can see the same patient, only simply just 15 minutes. Just the time that I need to remove the temporary to place the impression coping and to take the picture. And we can see how the soft tissues morphology is completely different in these situations. So if I take the impression, a normal and traditional impression, of course the dental technician will not have an ideal model where to work. And for sure the framework that we receive from the lab, for sure it will have many problems and it will require many adjustments. So what we can do in order to fix this problem and in order to be able to get a good impression, in order that also the dental technician can achieve an ideal model where to finalize our rehabilitations. And I want to show you a case that I treated in 2008, so maybe around 10 years ago. It's the same case that I already exposed to you, but what I can do in this case. So we want to show you how I connect the implant replica to the temporary restorations, and I put the temporary restoration with the implant replica inside a small box with some polyether or some silicone. And of course I wait for the complete setting of the material. It's the same concept that we have seen for the single tooth replacement. So I want to recreate the negative shape of the temporary in the subgingival portion. Once that the polyether gets the complete setting, I unscrew the temporary and I remove the temporary. And we can see how we have exactly the profile, the subgingival profile of the temporary restorations. So I screw the impression coping, and it's really important in this case to use not engaging impression coping because the abutment of the temporary restorations are not engaging. And I put in this case some acrylic resin in order to recreate the volume of the temporary. This is a case that I managed more than 10 years ago, so now after I want to show you also another cases, more recent cases where I use a new technique, but otherwise just to explain to you that we have been starting to use this technique around 10 years ago. So again, we wait for the complete setting. And then when the setting is finished, is concluded, we remove this kind of silicone impression K, acrylic impression K from the silicone. And it is exactly what we get from this process. It is exactly an impression K that allows to us to maintain and to support the soft tissues in the mouth exactly like the temporary. So in that way, when I will go in the mouth and I screw this K in the mouth of the patient, this case will be able exactly to support the soft tissues in the same way of the temporary. So I will maintain the soft tissues in the same way that I tested in the mouth per month. And this is really a crucial aspect. This is really an important secret in order to achieve stable result in terms of soft tissues morphology and of course also soft tissue stability. The problem of this material, the problem of the acrylic is the contraction, is the shrinkage. So in this case, in order to have a perfect seating of the coping on the implant, I had to cut the acrylic in the middle, otherwise the shrinkage doesn't allow to me to get the ideal seating of the coping on the implants. There is a reason why nowadays I don't use this kind of material, but I want to show you just to explain to you exactly the concept of this technique. So we take the impression using polyether or using silicone. It's up to you. It's not necessary to use always the polyether. It depends on the clinical situations. But of course, we use something like an elastic material, so a polyether or a silicone. In that way, when the dental technician will get the model from this impression, the model will be really reliable. And in that way, when we receive the framework, the zirconia framework from the lab, this is exactly what we observed. A perfect seating of the framework onto the implants and a perfect blending of the framework with the soft tissues, with really a minimal ischemia. So this framework doesn't require any kind of important adjustment. And it is really something really critical and important, in particular speaking about the zirconia framework. That is a material so reliable, so safe, so stable, but it's important to use it in the right way. This framework was finalized with the Emax crown, monolithic on the functional aspect and layer in the buccal aspect, and this is the final prosthetic outcome that we have achieved. And this patient has really an eye-lip line, and here we can see which is the static integration of our bridge in the smile of the patients, recreating a good incisal edge, a convex profile, and recreating also a good architecture of the soft tissues with a good pseudopapilla between all the teeth. And here I want to show you the stability of this kind of situations after 10 years. Just to explain to you if we are able to work in this way, paying attention on each details, it's possible to achieve really stable result also with a long follow-up, like 10-year follow-up. Here we can see the initial conditions, so the situation of the patients before the treatment. Here we have the baseline when we deliver the final restorations, and here is the follow-up after 10 years. 10 years after a GBR procedure that provides not only an horizontal but also a vertical rehabilitation thanks to the surgery of Dr. Emilio Maschera from Milan. But now I want to show you another case, a more recent one that I managed in 2014. This is a similar situation. We have bridges in the aesthetic areas. We have to finalize this case with 2 3-unit bridges. And it's important to be able to copy exactly this kind of morphology, this kind of soft tissues architecture in the impression, in order that the dental technician can achieve really a reliable model where it can work. And the technique, it was more or less the same. We connect the temporary restorations to the implant replica. I recommend to put some adhesive on the implant replica in order to have also a good chemical adhesion between the implant replica and between the silicone that we use to recreate the soft tissues morphology. Then we put the temporary connected to the implant replica inside a mass of silicone, a putty silicone, like a titanium, something like this. And then we go to copy exactly the more critical area, that is exactly the area that we have in the cervical portion of the restorations. We go to copy this area using some really ultralight silicone material, the same one that we use for taking the impression on natural teeth or on also implants. In that way, we are able to create an ideal morphology we are able to replicate in a really good way, which is the anatomy, the volume of the temporary restorations. Of course, it's really crucial and necessary that the temporary restoration is ideal, and we have to spend time to idealize it, working with the patient, adding composite or removing some composite if it's necessary, because my target is to copy exactly what I have tested in the mouth per month. Once that the setting is concluded, we remove the temporary, and of course also in this situation we have the perfect negative shape of the subgingival profile of the temporary, including the pontic areas. So we connect the impression coping to the implant replica, and then we fill all the negative shape of the subgingival profile of the temporary with a new material that is the Luxabite by DMG. That is really a good material for this kind of situation because it has really a minimal shrinkage. So it's really strategic in this kind of situation because it allows us to achieve a perfect sitting of the coping in the mouth of the patient without any kind of contraction and without the necessity to cut the silicone K intraorally. In these pictures we can see in detail what we have done. So we have copied the subgingival portion of the temporary. Then we connect the impression coping inside the silicone index using the dedicated impression coping in relation to the implant system that we used. And then we go to fill the gap that we have around the impression coping. We go to fill this gap with the material, with the Luxabite. This is a new blue material. The setting time of this material is really smart because it's around 1 minute, 90 seconds, something like this. So we don't have to spend too much time to wait for the setting. And when we remove it, we can see how we have a perfect design of my silicone K, impression silicone K, that allow to me to support correctly the soft tissues in the mouth during the impression. Because my target is to maintain the soft tissues in the mouth during the impression exactly like the temporary. In this picture we can see the intraoral situation during the impression. We can see that the blue material maintains the soft tissues exactly in the same situation like the temporary. The impression also in this case is realized with the silicone material. And this is the model, the analogical model that we get from this kind of approach. But nowadays I like also to work with a digital workflow. So I manage also this case with a digital workflow, with a complete digital workflow. And it is for 2 or 3 years that always I take a double impression of my patients in order to compare the two different approaches. And in this kind of situation where we have residual teeth in the mouth, the idea to manage this kind of clinical situations with a digital workflow is really strategic, because we can work taking 3 different intraoral impressions with the intraoral scan in order to be able to copy the volume of the temporary, so the morphology of the temporary. We can copy the soft tissues morphology before any kind of remodeling after that we remove the temporary restorations, and then we take another impression, a third one of the scan body. So the first impression is the impression of the temporary restorations, and it was finalized to copy the morphology of the temporary. In that way, the dental technician in the lab, with a completely digital workflow, will be able to copy exactly the morphology of the temporary that we have tested in the mouth per month. Once that we have concluded this first impression, we work with a second impression that is finalized to copy only the soft tissues morphology, the ideal soft tissues morphology. And how we can do this? We take the impression intraorally and we remove the temporary restoration, and immediately we scan the soft tissues. In this way, we don't give time to the soft tissues to collapse because we copy immediately their morphology. In that way, we are able to collect exactly the morphology that we need in order to finalize the restoration in a really good way. Then we take a third impression with a scan body, And this third impression is finalized just to copy the 3D implant position in order to know exactly where the implant is located in the mouth. And in that way, we have the chance to create an ideal model in order to have a framework with a perfect passive fit. So we need 3 different intraoral scans. And the software put together all this information in order to achieve, in the end, a really good digital model that the dental technician can use to produce the framework, to do the wax up, to finalize all the restorations that really often can be also finalized without a model, so with the model-free approaches. In this case, we decided to work with a cutback on the buccal aspect because we decided to work with a layering approach on the buccal aspect for aesthetic reasons. So of course in this situation we need a model. But anyway, if it's not necessary, we can also work without any kind of model. In this short video we can see how is the digital planning of in the lab, working on the profile, working on the shape, evaluating the screw hole access and all the prosthetic details. In that way, when we finalize our digital design, we obtain the framework. In this case we are speaking about 2-3 unit bridges in zirconia, with a cutback, a vestibular cutback, in order to proceed then with the specific buccal layering. And here we can see in this picture the intraoral evaluation when we go to try-in, when we go with the try-in of the framework in order to evaluate the seating, the passive fit, and at the same time all the aesthetic and functional parameters. It's really interesting to see how nowadays with the correct surgical approach it's possible really to maintain the morphology, the preliminary morphology that we had before to extract the teeth. So in this case, for example, with the mid implant placement, with an immediate function, in combination with soft tissue graft and bone graft, we are able to maintain the soft tissues exactly in the same position that we have in the beginning of the therapy. And now we finalize the treatment, we do our layering approach on the buccal aspect, and now I want to show you how is the seating of the bridge in the mouth with this kind of technique. You can see how when I try in the framework and the bridge in the mouth, we don't have any kind of ischemia. The framework and the bridge gel perfectly with the soft tissues. We have a perfect blending, and the framework and the bridge doesn't require any kind of adjustment. So we spend 50 minutes to take a better impression, but we save 1 hour at least of time to adjust the final result that really often, if we don't work with this kind of approach, are necessary in order to have really a good prosthetic outcome. And also in the opposite side we can see the same thing. The combination of the bridge with the soft tissues is really good. We have a perfect blending and we don't need any kind of adjustment. And this for me is a crucial aspect also in terms of reliability, because when I can, always I like to don't drill the zirconia intraorally and after the sinterization process for the risk to overheat the framework and for the risk to create fracture and crack inside the zirconia. Now, in this picture we can see the final prosthetic outcome, a good soft tissue integration, a good pseudopapilla, a good morphology, good volume, and also the bone integration is really good. We can see also how the stability of the bone around our implants is really good, and we don't have any kind of bone loss after the prosthetic delivery. So we have seen the treatment of the single tooth replacement, we have seen how to take a good impression, so in case of single tooth replacement and also in case of partial rehabilitations in the anterior segments. But now we have also to face with another important aspect, that is the management of the full arches. In this situation, the impression is really critical. We know that when we face with the treatment of the full edentulous patients, we have 2 different approaches. We can have a dental bridge solutions without any kind of pink reconstruction, or we can have an hybrid bridge, an hybrid solution that requires a pink reconstruction because we are in a situation where we had a really bone loss, so we have an important atrophy. Of course, the treatment plan of this kind of therapy is completely different. Because if we have to face with a dental bridge solution, of course, the target of my therapy is to have a perfect blending of the restoration with the soft tissues, achieving good proportion of my rehabilitation of my teeth and achieving a natural aesthetics. While if I have to face with a hybrid solution, the main aspect that I have to evaluate is the position of the transition line between the pink reconstruction of my prosthesis and the real soft tissues that we have in the mouth. And the most important thing is to maintain this transition line under the lips in order that the patient absolutely doesn't show this transition line, know when he's smiling, know when he's speaking, and during, of course, the function and the phonetics. And of course, the treatment plan of these two different approaches are completely different in terms of expectation of the patients, in terms of what is the aesthetic evaluation, what is the soft tissue management, the implant therapy, the implant placement, and of course also the maintenance. So it's really important to be able to evaluate this kind of aspect in the beginning of the therapy. Before to start with the therapy, before to start with the implant placement, is really important to understand in which kind of situation we are with our patients. And also in terms of soft tissue management, the situation is really, really different. In fact, when we have a dental bridge, the profile of the soft tissues is like a sort of ovate pontic, because we have to push to create a good morphology, to create a good pseudopapilla. So this kind of approach in case of a dental bridge requires more times in order to idealize and finalize the case. Otherwise, when we work with a hybrid solution, the design of the soft tissues are really poor, because normally we have a flat profile of the soft tissues, and we need a flat profile because it is the flat profiles that allow us to have a good maintenance of the framework and from the patients in terms of oral hygiene. And it's the flat profile that is really necessary also absolutely for the oral maintenance and for our dental hygienist, and of course also for the patients at home. So in case of hybrid solution, so in case of soft tissues flat profile, like in this situation, the plaster is really a good solution. The plaster for the impression is really a reliable solution in terms of 3D implant position. And this material allows us to achieve really reliable model where the dental technician, using a good CAD/CAM technology, is able to achieve a framework with a passive fit. And in fact, in this situation, it doesn't matter to copy the soft tissues morphology. We have just to copy where the soft tissues are. Because again, we have a flat profile of the soft tissues, like how we can see in these pictures. That's a typical case of Holon 4, and we can see how the soft tissue are really flat. This is another case. Soft tissue are not conditioned at all, but are completely flat in order to simplify the dental cleaning and the oral maintenance. In this way, of course, working with a good impression, we can achieve this kind of framework that can be realized in titanium or in zirconia in relation to the biomechanical aspect that we have for each patient. And in this way, we can achieve this kind of result that give us the chance to recreate really a good aesthetics and a good function for the patient. Also, in case of full edentulous patient, it's possible to consider the approach of a digital workflow using the scan body. In this situation, of course, it doesn't necessary to copy exactly the soft tissues morphology because, again, we have a flat profile, so it doesn't necessary to copy the soft tissues immediately after the removal of the temporary, because the profile is really flat. The problem is that when we work with an intraoral scanning in case of full edentulous patient, the reliability of the impression technique is not so easy to achieve, because it depends on many aspects. Because you know that when we work with intraoral scan, it's important from the software, from the software standpoint, to have reference inside the mouth. And if we don't have teeth, we don't have a lot of reference. So it depends on many anatomical aspects if the intraoral scanning can be reliable or not. For example, if we consider this kind of clinical situation, we know that in the literature we have many studies that describe that the performance of the intraoral scanning is really high, but the majority of the studies are made in vitro. So of course the performance of the intraoral scan is really good, but it is important also to evaluate how is the performance of this machine in the mouth, where we have many variables like the saliva, like the micro movement, and we know that in the mouth we have situation with lots of keratinized mucosa, situation where the keratinized mucosa is really reduced, so the situation can be changed a lot. In fact, if we consider not the in vitro study, but if we consider mainly the in vivo study, we can summarize how the digital workflow is really good in case of single or partial rehabilitations, but in case of a long span of bridge, long span restoration or full arches, it's important to pay attention on these approaches. And of course, it's really important to stress the aspect that really we need a learning curve. So it's not true, it's not easy, it's not completely true that if we work in this direction, we can immediately change our old approach. It's necessary also in this case, like in all the procedures, a good learning curve. In this case, for example, we can see how if we compare the digital with the traditional workflow, sometimes it's not easy to say that the result is the same. Because considering a specific study that we're doing with some clinicians, I can summarize how the presence of keratinized mucosa, the implant depth, the implant angulation, the pontic size, and the presence or not of the fornix, or the jaw size, the operator, and also the quality of the scan body are all crucial factors for the reliability of the impressions. And of course, in the upper jaw, when we have the palate, the reliability is much better because it's much easier for the software to find the reference when the software working, creating the stitching between all the pictures that are made in the mouth. But now it's important to consider the dental bridge solution. So where the soft tissues are not flat, but are scalloped, like in this case, where we work a lot with the temporary in order to recreate a good design, a good morphology, a good pseudopapilla. And in this situation, of course, we have the same problem that we have already seen in case of single tooth replacement and in case also of partial rehabilitation on implants in the anterior segment, in the anterior and aesthetic segments. And I want to again repropose to you these pictures, this slide. This is a full edentulous patients. Immediately when I remove the temporary, this is the situation. When I place the impression coping, I took the X-ray, so simply after 15 minutes, I take another impression and we can see how the situation is completely changed. So how we can fix this problem? How we can how we can achieve a good impression in order to give the chance to the dental technician to work in a really reliable model. So we can fix this problem using a double impression technique. So I want to show you exactly what I mean in a really practical way. In this slide, in this picture, we can see the temporary restoration in the upper jaw. And the first thing that we have to do is to remove the temporary restoration in the upper jaw, that it should be perfect in terms of functional, aesthetic, and soft tissues morphology, soft tissues architecture. And we remove the temporary and we take a first impression with the plaster. The target of this first impression is just to copy the 3D implant position. We don't care at the moment on the soft tissues. And again, this is the specific situation of this case. We can see how the soft tissue are immediately after the removal of the temporary, and this is how the situation is after 15 minutes. We can see how the pontic area is flatter than in the previous pictures. So of course, the same story. If I take this impression, the dental technician will not have a good model when he can realize a good framework and a good rehabilitations. So first step, impression with the plaster. So we screw the impression coping in the mouth, we have an individualized impression tray, and we take the impression with the plaster. The plaster is really a good material, really reliable, easy to use, and really can give us the chance to achieve really good framework with a passive fit if we work with a good CAD/CAM technology. Once that the setting of the plaster is concluded, of course we go to remove completely the impression tray from the mouth, and this is the normal approach that we also do with the other kind of material like the polyether or like the silicone. And when we remove the impression, this is exactly what we have. Of course, this impression is really good in terms of 3D implant position, but in terms of soft tissues morphology, is absolutely not good. So we ask to the dental technician to create a model for this impression, like normally they do in the normal routine. So we create the soft tissues morphology using a pink silicone, and then after that we go to pour some model, we go to pour some plaster on that in order to create the models. And it is really important to create these soft tissues, not because are important to finalize the work, but it's important to create them just because I want to remove them from the model. And if I don't create this kind of soft tissues, for me it's impossible to remove them, and I have to drill the model with some burrs or some drill, and it's more complicated. And I have also the risk to touch the implant replica, and so to compromise the reliability of my rehabilitations and the precision of my rehabilitation. Once that the dental technician sent to me the model that we have achieved from the first impression, I ask to the patient to come in the office again. And I remove the temporary again, and I use the temporary restorations like an individual impression tray. So I put some material like a silicone material, silicone impression material on the pontic area of the temporary. And of course I put the same material also in the mouth, in the pontic areas, because I want exactly to use the temporary restorations to copy the soft tissues morphology in the mouth when the temporary is correctly screwed in the mouth. In that way, my silicone is able to copy the soft tissues morphology exactly in the same way that we have in the mouth when the temporary restoration is correctly screwed. So we check the position with the occlusion, and then of course we screw the temporary restoration intraorally. And this is what you achieve after the complete setting and when we remove it. And we can see that in some area, in the pontic area, we don't have the material because we have an ideal compression. But in the other area, we can see how we have some material, we have some spaces. And so it is exactly what we need in order to have an ideal soft tissues reconstructions. So now I place the healing abutment in the mouth of the patient and I ask the patient to wait 15 minutes in the office. And I go in the other room and go to my lab. We can do this kind of approach alone, or we can also ask the dental technician to do this job. It's important to isolate the silicone that we use to take the impression in the mouth with some isolator. And then what do? We remove the initial soft tissues from the model. So we remove completely the pink reconstruction, the soft tissue reconstruction, and we go to recreate a new soft tissues morphology on the model that we get with the first impression with plaster. So we can see how we put some silicone, pink silicone material for the soft tissue reconstruction on the temporary, and then we go to screw the temporary on the model. In that way, in the model where we are able to create a good 3D implant position thanks to the impression with the plaster, now we are able to create the ideal soft tissues morphology thanks to the impression took with the temporary restoration and with some silicone material that normally we use for our impression in the tissue support rehabilitation or for implants. Of course, we put the material also in the pontic area on the model in order to avoid any kind of bubbles, how you can see in the video. And in that way, again, we are able to have an ideal model, and a model that maintains the reliability of the plaster in terms of 3D implant position, and at the same time the reliability of the silicone and the temporary restorations for the soft tissues. So we have seen the treatment of the single tooth, the partial rehabilitation and the full arches with different approaches, but the concept is the same. I want exactly the soft tissues that I have created in the mouth with my temporary, and I have tested per month in the mouth thanks to my temporary restoration. Now, once that the setting is concluded, we go to remove our temporary from the model. It's crucial to have placed the Vaseline, the isolator between the silicone, and otherwise it's difficult to remove and to remove the silicone material from the soft tissue reconstruction. And now it's interesting to see how, if I try to place the temporary restorations on the soft tissues that I've took with the second impression, you can see from the video how the combination, the blending between the temporary and the soft tissue is ideal. So on this model, the technical technician can really realize a good framework. But if I put on the model the first soft tissues that I got from the plaster, and now I try to put the temporary restoration on the same model, you can see how I don't have any chance to have a good sitting, because the soft tissues are completely different. So how we can think that our dental technician can create a good framework, a good rehabilitation on this kind of models? And this is really a key point that really makes the difference. And also in this slide, you can see the difference between the seating of the temporary on the soft tissues that we have took with the silicone and the temporary, or the soft tissues that we have took with the plaster. And in that impression that we have took with the plaster, we don't have any chance to have a good seating, because the soft tissues are completely different. And so if we ask the dental technician to create the framework on this model, for sure, when we receive the framework, we will have an important ischemia, an important compression of the soft tissues, and we need lots of time to adapt the framework with the risk to create crack, to create problems to my framework, to my structure. And also here we can see the difference between the two models. This is from the silicone on the left side, and the other one with the plaster. And we can see how it's different. It's completely different morphology. In that way, I asked to my dental technician to create a full arch rehabilitation on 4 implants in full zirconia, in monolithic zirconia. And when I go to screw it in the mouth, this is exactly the result that I achieved. A good blending, a good combination of this framework of my profiles with the soft tissues. And this is exactly what I want for my patients, in particular when we work with the old porcelain approaches. And this is also the key factor in order to have stable result. Because if I test the soft tissues in the mouth with my temporary per month, and then I maintain them in the same situation also with the temporary, of course, my soft tissue will be stable. But if the morphology that I created with the mouth, I'm not able to maintain this kind of morphology with the final rehabilitations, of course, my new framework, my final framework, will be support the soft tissues in a different way, and so of course, I will observe a modifications of what I have created with the temporary. And this is the final prosthetic outcome that you achieve in this situation. We have a dental bridge solution in the upper jaw without any kind of peak reconstruction, and we have in the lower jaw a hybrid solution. So we have a solution with a pink reconstruction and absolutely with the flat profile. In this picture, we can see the integration of the rehabilitation in the face of the patient with really a good integration and a good natural appearance. So really, I recommend to use this kind of approach, in particular when you use monolithic zirconia, or in particular when you use an old porcelain approach, because with this kind of material it's really important to try to avoid as much as possible all the adjustments that sometimes we need in order to adapt the framework, in order to achieve a perfect blending of the framework and the structure with the soft tissues. Thank you for your kind attention.